I just want to thank all of our panelists and the audience, for all of you who are still here from the morning. Thank you for staying. My name is Erin Hasselberg, and I'm the director of the Pharmaceuticals program here at Boston University School of Public Health. And we are switching up the agenda a little bit. I'm going to come back to you in just a few minutes to talk to you more about the program. But I'd first like to introduce someone who you've heard from already today, but someone who a lot of us know and has a lifetime of experience, really, in pharmaceutical public health. Someone the BU community knows well, and many of you. How many of you know Richard Laing personally or professionally? Okay, a number of us. And you have his bio in your program, but I want to tell you a few things about him that you don't know that are not in the bio. He's, as many of you know, he's a professor in the Department of Global Health here at BU. He's also a professor at the University of Western Cape in South Africa. So he strategically spends his winters from Boston in South Africa in the summertime. Smart man. And at both schools, he teaches about pharmaceutical public health, a lot of what you've been hearing about today in this newly emerging discipline. His journey in his career has spanned government, multilateral institutions, academic institutions, non-governmental organizations, and crossing paths with many of the speakers today. I almost think that some of today is like a "This Is Your Life" Richard Laing kind of coming together a little bit. But he started off he's trained as a medical physician and started off working at the Ministry of Health in Zimbabwe. And worked in the ministry for more than 18 years, but started his journey in essential medicines in November of 1986. So that was 30 years ago. So he has been working in this space for 30 years. I'm almost that old, right? And in that time, in 1989, he actually crossed paths with Jono Quick, who is just our moderator here today. And Jono recruited him to come to Management Sciences for Health in the United States, where Richard helped establish the International Network for the Rational Use of Drugs, or INRUD, for those of you who know that. And while at MSH, he working in this space, also interacted with a gentleman named James Wolfe, Dr. James Wolfe, goes by Wolfie here at the School of Public Health, who was then an MSH consultant and also working here at BU. And he brought Richard over to BU and said, "Hey, help teach my class." And Richard made a lot of contacts and friends here and stayed for 7 years and helped establish the Global Health Department here at BU. And while doing coursework here, he also started interacting on a global scale and conducting courses on pharmaceutical policy and interacting with WHO. And what happened? WHO really liked Richard as well. And so he moved over, after 7 years with BU, moved over to WHO in Geneva as a medical officer and worked in many areas related to capacity building in pharmaceutical policy, rational use, medicines pricing. And in that fora, started also interacting with a lot more pharmaceutical manufacturers around issues of access. And so where he came in contact with many of our panelists and guests who are here today as well. So quite a journey. He then came back to the School of Public Health. We've been very lucky to have him back, and is a very well-established, has a very well-established list of academic publications. He's an award-winning teacher here at BU School of Public Health and a very strong advocate and mentor for many of our students here, and as well as to me. And I have the honor of not only calling him a friend and colleague, but to introduce him to all of you a little more personally today and welcome him up to give you his perspective on this newly emerging field of pharmaceutical public health. Richard.
Thank you very much. And when I hear something like that, I almost need to pinch myself and think, what's this little person from the rural Zimbabwe doing in a place like this? And for me, WHO was the temple on the hill when I first got there. I learned that the temple had foundations of clay after 10 years. But my wife and I were both born in the same small rural hospital, same year, same doctor, we think. And for me to gravitate and end up in a place like this is just amazing. And I remember George Bush, and I'm not a big fan of his, but he said, you know, anybody can do it. And he did it. How well he did it, I'm not sure. So what I'd like to talk about is this overview of pharmaceutical public health. We've had the two symposia, the two sessions, and that. And what would like to do is just to share, and I ran through some of these slides last night at our dinner for the speakers, is to say that where are we going with this? And what am I pitching? What am I pitching to Sandro? What am I pitching to Pitt? What am I pitching to all of our epidemiologists and biostatisticians in our department and in the school? How can we go forward with this? And this is the point that Jono, he mentioned, and it's this idea that progress often comes from between disciplines. For people who are within a discipline, they are constrained by the nature of that discipline. There's the right way of doing things. That's the way we do it. And whether it's public health or pharmaceutical science, everybody is constrained by being part of that discipline. But once the disciplines start interacting, you suddenly have the public health people saying to the pharmaceutical people, what are you doing about the health challenges for communities? And sometimes the pharmaceutical science people are saying, well, we need to distribute our medicines. How can we do that better using some public health principles? And so what I'll talk about is where does this interaction happen for the next 10 or 15 minutes, and then it'll lead into the discussion that Erin will have about the course. The first area is innovation. Sorry, let me just go back if I may. Here, when we look at pharmaceutical science, I'll be talking a little bit about innovation, a little bit about quality and safety, and quite a lot about access. And where does it fit? Where does innovation fit in? And here's a report. This is the 2013 report. There was a 2004 report, and Warren Kaplan, if he's still here, was one of the areas, the key authors. He and I were the authors of the first one, and the five of us did this one. And this was a report commissioned, the first one commissioned by the Dutch government, to say, we want to invest in the pharmaceutical sector. And they were estimating at the time about €250 million over a 5 to 10 year period. And they said, could we prioritize our investment on the basis of innovation? And they did, and they spent the money. They got a whole lot more, in fact, came in. And then in 2010, the European Commission was moving towards something called IMI, the Innovative Medicines Initiative, which was much more money, but it was for the whole of the European Union. And again, they came back to WHO and said, could we update this priority setting study? And it was traditional public health. It was global burden of disease. Where is the burden of disease? And then we looked at the pharmaceuticals and said, for those diseases, where is the effective treatment existing? Where are the treatment gaps? Where are we going to lose effective treatment? Antimicrobial resistance, anti-malarial resistance, and issues like that. And we produced this report. I do think the first report, you never know how long it takes for some of these recommendations to be put into practice. I was quite gratified that at different times, after the first report, you would see paragraphs out of the report cut and pasted into EC calls for proposals and things like that. So it does happen. So the second area of pharmaceutical public health that really has a long track record is quality and safety. Now, quality in high-income countries, in general, does pretty well. But in low and middle income countries, it's very patchy. And that's why the work by Pius and his relatively small team with relatively low technology and a very active approach is, to me, a very good example of work that's being done. The second is the work by the World Anti-Malarial Resistance Network. And Paul Newton is here, and he has organized this from Laos, collecting information on all the episodes of malaria treatment failures. Where is the medicines going? And this, I think, is one sign on the quality. When we talk about pharmacoepidemiology and pharmacovigilance, this is very well established. And the whole idea of safety, that as one of the CEOs of one of the pharmaceutical companies says, our companies do three things. We develop medicines, we make sure they're safe, and we sell them. And it's the making sure they're safe and keeping them safe and monitoring them is where we have very good. We have both Sloan and the Boston Collaborative Drug Surveillance Program. So we're very well resourced as far as that goes. We haven't yet been able to really merge all the work together as much as I'd like to see. But I think as we see particularly the new antimalarials coming out in Africa, we will see more interest and effort to look at the safety issues there. Now, when we come to access, and this is really where it gets a lot more complicated, what does access mean? And access is a bit like faith, hope, and charity. It all depends who you talk to. It's a belief structure. I like very much this Bigdelli framework. Mariam Bigdelli is at WHO, and she's developed quite a complex structure, but if anybody who wants the slides, this is a link to it. But some of the key issues in access: selection, procurement, distribution, rational use, financing, pricing, intellectual property barriers, information sharing. The procurement and distribution, I won't be talking about today. There's lots that could be said, but it's not something that I've been particularly involved in. But the others, at different times, I have. The first issue is the Lancet paper, 25 years of the essential medicines. And WHO has taken the lead with defining. And I think there's all sorts of concern about intellectual property and the conflicts that are going on. But putting it in perspective, 1977, when WHO announced the first essential medicine list, was an absolute bombshell. Because if those 216 medicines were essential, what were all the rest of them? All the other medicines on the market, were they not essential? And for nearly 20 years, the US and a couple of other major drug exporting companies stopped paying its dues to WHO because they were so unhappy about the decision of the essential medicines list. But now we've got many studies. Veronica's done a fascinating one with Michael Reich on the economics of what happens with that. But the opportunities, the number of studies have compared lists over time. How do those lists evolve as scientific knowledge changes? Do neighboring countries have the same lists? If they don't, how is it different? And in China, the supplementary list, there were some states, some provinces which had, I think, 9. I think Shanghai had 300 extra. So we had 2 students, one from here and one from Canada, spent their time doing a comparative analysis of the 24 provincial additional lists to say where was their commonality and where was their differences. And I think we're seeing now more and more opportunities to apply the same messages to high-income countries. Many insurers, many hospitals have formularies. They don't call it essential medicines lists, but they're formularies or they're reimbursement lists. What's the rationale for deciding on that? And we've moved, WHO, has moved from what was called experience-based selection to evidence-based selection. There's a much more disrespectful term for experience-based. Anybody know what GOBSAT stands for? GOBSAT? Good old boys sitting around the table. That was the model that used to be used. Oh, I'm in trouble with this. Okay, the rational use, and this is where Jono and the team at MSH really pushed things forward. I'd been working in Zimbabwe on the essential drugs program there, really focusing on, we did selection, we did the procurement and distribution, but we really focused on use to rationalize, limit the number of medicines, but use them as well as possible. And MSH picked that up and said, let's have a network. And the first activity of the network was to measure, and methods are important. So we measured drug use with standard drug use indicators. This was published in '93. It's now in its 9th edition. And every time we say we want to revise it, people object terribly because they've used it so often. And what we discovered was that the range of use of medicines, the quality of the use of medicines, particularly in Africa, varied from the east, where it was very good, in Tanzania, for example, to the west, where it was much more problematic. And Indonesia had children receiving, 60% of children received 1 or more injections. And I remember Jono was involved in that study. Once we knew how to measure it, we were able to evaluate interventions. So we had a whole body of work coordinated primarily by the group at Harvard and the Drug Policy Group, looking at interventions that could be used in country, low budget, that could change the way medicines were used. And just recently, 2014, Kathy Holloway and David Henry did an analysis of about 850 surveys that had been done and compared the results of those surveys with national drug policies. And what they were clearly able to demonstrate was that national policies that were focused, that were related to improving the use of medicines, had an effect on the use of medicines. So countries that made an effort had a good result. Financing and pricing, and we've heard lots about some levels of pricing. This is the manual that WHO and Health Action International put together. Margaret Ewan has been responsible for coordinating that. And one small aspect of it was that the partnership between WHO and Health Action International allowed to put all the data on a database, a publicly available, searchable database held by Health Action International. And at the time I thought, oh, it'll be more efficient, it'll be cheaper, their costs are less. But what I discovered once I was at WHO for a long time is that member states have the power to prevent unfavorable information being posted on WHO websites. And that meant that what we got on the HIE website was far more transparent. So now anybody, it's a searchable, you can go there and you can find out what medicines are being used, what price, etc. Now, that's all very well for low and middle income countries, but could these methods be applied in high income countries? Could they be applied in Boston? And I'm blessed with very smart students. And in 2014, Abhishek Sharma sitting at the back, the students did a survey, representative survey of pharmacies within the 128 area, stratified by independent and chain pharmacies. And some very interesting findings came out. The independent pharmacies were consistently cheaper than the chain pharmacies. But the cheapest medicines by far, the lowest cost medicines in this area, are at Walmart and Target. And you can buy simvastatin at Walmart or Target at a price lower than a retail store in Delhi. Delhi, the price ratio would be about 8 times, and here in Walmart and Target, it was about 4.4. So there are things we can learn from this. Now, am I saying that the generic medicines being sold in the chain pharmacies were cheap? No, they were the most expensive anywhere in the world. Nowhere else has such consistently high prices. But their ratio was 30 times the international price. The chains were nearly, I think, about 20 times. So there's lots of opportunity for improvement, but I think these are the methods that can be used to help us go forward. Now, the last couple of areas that I'd like to just use for talking about that I think are very important as we move forward. And transparency in pharmaceutical issues benefits many, is often resisted, particularly the regulatory agencies. For some reason, regulatory agencies have a knee-jerk response, is all information should be secret. And when I say that, it's, when will your next meeting be? Nope, that's secret. Who are the members of your regulatory panel? That's secret. What medicines are registered in your country? Well, that's not secret, but you'll have to pay for it, and it'll take us 3 months to give you the disc or whatever it is like that. Absolutely no good reason for secrecy like that. And some of you may know, we have been commissioned by Novartis to evaluate Novartis NCD Access Initiative, where they are rolling out a program to provide 14 medicines at a cost of no more than $1 a month for those medicines. They're starting in Kenya. And they said to us, would we evaluate? And we said, yes, but we have to be transparent. So the proposal is on the website. The award is on the website. The protocol is on the website. And we're actively collecting data at the moment, but when we have clean data, that will go on the website so that people will have an opportunity to know and understand. And we're trying to apply those methods to other companies that are talking around saying, can we help with them with evaluation? That we had the discussion about payment and quality information. And I just want to show one, again, this is Warren Kaplan's work, is who would think data from the World Trade Organization on customs tariff volumes would be useful for public health? And lo and behold, we have this very confusing chart. But let me explain it because it suddenly gets very simple. This is insulin trade network. Yellow is exporter, red is importer. The thickness of the line is the volume moving in those different areas. And what do we see? We see Denmark, Germany, and France are the major foci exporters. The US over here is more than 75% importer. Eli Lilly is only less than 25% importing. And we see some of the other countries that are exporting over here. I think is that China over there, India and China, and Margaret Ewan has been, and her colleagues have been visiting some of these factories. And so we see what's going on. Now, when we visited Denmark, we said, oh, that's a concentration of production. More than 50% of the world's insulin comes there. What happens if you have a tsunami? And they said, oh no, that only happens in Japan, and Denmark, we're safe. I hope they are. They tell us that they have a year's stock of crystals which are stored at room temperature in other sites. But I think this is something, and this came out of Warren fiddled with the data, and I think you had a mathematician and a geomapper down here, the names over here. So another approach of different methods. The intellectual property, I knew we'd get into it this morning, and I think the key, for me, the key message is while IP is seen as the basis for innovation, this does not always benefit low and middle income countries and neglected diseases, whether it's neglected tropical diseases and in low and middle income countries, the orphan diseases. One of the problems we face is that the trade agreements may create barriers to access far beyond what was imagined. And one of the biggest problems is that the trade negotiators, Peter had that very nice story of his evening on the beach in Maui, commiserating with a trade negotiator. But for many of them, they are being thrust into an amazingly complex environment, making decisions that will have lifelong impact on the access to medicines in their countries. The other point that we made, and we discussed generics a little bit this morning, but pro-generic policies are good, but not if branded generics are conflated with INN generics. What we see in India is that some of the Indian generic companies are overpricing the originator companies. They're charging more and gaining market share because of a lack of confidence in the regulatory bodies in the different states, and people think, well, if I pay more, it must be better. And unfortunately, they end up paying a lot for little. So this is my last slide, and then Erin will take over. That BU is the only school of public health with a substantial pharmaceutical public health program. And while I'm proud for BU, I hate to say I had 10 years at WHO, And my job description was to improve public health in schools of pharmacy and pharmacy in schools of public health. And I just didn't succeed, except with BU, and we got them started beforehand. Schools of pharmacy, you would hope, would be interested in this area, but what we're seeing is the social pharmacy programs are declining. They're less prominent. So there are great opportunities exist for teaching, research, service, consulting for schools of public health to contribute to this emerging area of study. So I'm now going to ask Erin to come, and Erin is a multitasking individual. She spends 60% of her time at MIT doing the logistics and service for their emergency preparedness. She does 40% for us. She's bought a house and she's painting the house. So Erin, go ahead.
I'm gonna go. Okay. Thank you. Yes, so I've been actually excited today that supply chain made it onto the topics to be talked about. That's what I do in my other 60% of my life over at MIT, working on supply chains and movement and distribution of medicine. So when Marg was talking about availability of medicine, a lot of the availability issues are around supply chain. So I was glad that we got some attention today. But I'd like to first put a question, before I go into some of the details about the program we have here at BU, I'd like to first put a question to all of you in what are you or your organization or your company doing to advance pharmaceutical public health? You're all here today because you're apparently interested in the role of pharmaceuticals in public health. So I'd like for you to think about that question. I'm going to go ahead and answer from BU's perspective first and tell you a little bit about what BU has done, is doing now, and hopes to continue to do kind of going forward. So we'll start with a little bit of history. So the pharmaceutical program at the School of Public Health was actually started in 1997. Dr. Louis Kazis and others created this program initially, had half a dozen students or so, and focused on assessment, management, and policy issues around pharmaceuticals. In 2011, fast forward kind of almost 14 years later, Dr. Chris Gill, who came back to BU from his time in Novartis Vaccines, came back to run and kind of revamp the pharmaceutical program. And one of the things he established was an annual student-run symposium series. So we have this every spring. Many of you have probably attended a few of those over the course of time. And we saw student enrollment increase to 20, 30, 40 students over the course of the last few years. In 2015, I came over to BU and took over from Chris so he could concentrate more on his research and became the director of the pharmaceuticals program. And we saw in 2015 that we had our largest ever information session. We had a lot of interest in this area. We formed a student leadership council. And this year, the pharmaceutical program is now one of 17 certificates in the new School of Public Health MPH curriculum. And this program is now, always has been open to any MPH student, so any MPH student who's interested can enroll. And we currently right now have about 70 students enrolled, not including the new class. So have a lot of interest in this area and are hoping to continue to grow in this area. And we've had more than 150 graduates to date so far. So we have many of our graduates out there advancing the field of pharmaceutical public health. And a little bit about how we're advancing pharmaceutical public health from our certificate perspective. The certificate is 12 credits worth of coursework. That includes a semester-long foundations course, Pharmaceuticals and Public Health, that covers everything from drug development and discovery to regulatory to supply chain management to quality and pharmacovigilance and safety, so that students get a very good foundation in a lot of different areas and then can fulfill the rest of their 8 credits in a number of areas, from policy to management and implementation and drug discovery and delivery. Students are also required to complete a skills-based practicum of 240 hours as part of the certificate, and we have students locally based at pharmaceutical companies, at the VA, the Veterans Affairs Hospital, and also internationally, working in different WHO offices and the Gavi Vaccine Alliance. And outside of those requirements, we do offer other things for our students in terms of seminar series and our, as I mentioned, the annual student-run symposia and many networking and social events. So a few pictures here for all of you. But I'd like to actually ask all of you in the audience, some of you are already advancing pharmaceuticals and public health. So how many of you are a current student at BU School of Public Health in the Pharm certificate? Of the few who are left, stand up. Stand up if you, we'll get everybody. Okay, we have 2 in the room here. A few. Everyone. A lot of students have class right now from 2 to 5. We have faculty. So if all the faculty from BU or otherwise, if you're a faculty member in the Boston area or anywhere else, and you teach or do research related to pharmaceuticals and public health, stay standing up, my students. And faculty, please stand up. We're going to do a little. Yeah, you're faculty. If you're working at an organization and you know that you hosted a student or had a student intern, stand up. Okay, so we have a few. So thank you. All of you are advancing the field of pharmaceutical public health, whether you knew it or not. So you can sit down. Thank you. And as I said, we have our annual symposium, and another way that we're advancing pharmaceutical public health as a discipline is trying to expand and engage the community in Boston here. We have a large, if you didn't know, a very large life sciences community here in Boston, and our student-run symposium last year was past spring was focused on the politics of access. We had a former Assistant Secretary of Health and Human Services, Dr. Howard Koh, keynote, and a lively panel that featured payers, patient advocacy organization, pharmaceutical industry represented by MassBio and academia, talking about how do U.S. government policies impact access to medicines. And so we're trying to push the envelope a little bit and get people to engage and share in these kind of events at the school that we're hosting. And then another thing that we do in terms of advancing public health is we try to engage also externally. We have an external advisory board for the program. Vin Sharma, who was on the first panel this morning, is a member. A few other members were here earlier today. But we really we meet every quarter for an hour, and we engage with industry, with foundations, with consulting firms to see what are their needs, what are they thinking about in pharmaceutical public health, how can we incorporate those things into our curriculum, into events, into things that we're sharing with the students to really keep things moving forward. And of our 11-member board, we have 5 BU School of Public Health alumni, and 3 of whom are graduates of the Pharmaceutical certificate. So they themselves are out in the world also advocating and advancing pharmaceutical public health. And of course, our alumni, we have a few alumni in the room. Would you, alumni of the Pharmaceutical certificate, want to stand up? I know there's a few. And Kate can stand up too. Okay, Abhishek is here, and Kate. Yeah, and Paul, great. So and we have alumni working in various areas. Our students go on to work for non-governmental organizations, in industry, in CROs, within government, so influencing various areas. And they're our best advocate and also the best way to advance pharmaceutical public health. And Boston, as I mentioned, was ranked last year as the #1 place for life sciences. So our graduates have ample opportunities for jobs. There are more than 82,000 jobs in life sciences in Boston last year, and it accounted for $7.2 million of the state payroll. So lots of opportunities for work and for practical opportunities. So we're proud to keep doing that. And today and into the future, we're continuing to advance the field of public health even outside of just our pharmaceutical certificate, and looking for additional opportunities in academics, not just with our current MPH students, but looking to new degree programs, new MS programs, new short courses for executives in particular areas that are of interest that we can kind of continue to engage that way. Looking at research, we have many faculty doing research in this area, whether it's on patient adherence, whether it's on access to medicines. Richard mentioned some of our consulting that we're doing with Novartis and access to medicines and evaluating those things. So these are all part of our portfolio of work that we're trying to grow, as well as looking to the community and our alumni network to continue to advance this newly emerging discipline of pharmaceuticals and public health. And with that, I leave you with your question. Do you remember your question? How are you advancing pharmaceutical public health? What is your organization doing? What are you doing as a student if you're studying? What are you doing as an alumni? All of us, I hope, taking a lot from today and from all of our different panels, can walk away to be able to and think about hopefully some nugget stays with you of how you're advancing this work, because it is very important. It's very important to public health. We've seen some of the impact that medicines and pharmaceuticals can have. So I'm excited to have all of you here and to share all of this. I welcome collaboration. If you have ideas, please come talk to us. We also have an information table over here on the side. If you want more information about our program, you can put your email and things there, and you can find more information at our website there. So with that, I think Richard and I are going to take some questions, and we'll move over here for a more intimate conversation. So we'll just take any questions that you have, either based on the program, based on what Richard presented, or anything from out the course of the day. We realize we stand between you and the reception, so. Any questions? Yeah.
Richard, you said that you spent 10 years trying to encourage people. That's to me not a discouragement, because there are lots of important things that have taken a lot longer than 10 years. But what are the lessons of those first 10 years in terms of where do you think people were? I mean, you think it's a passion. I mean, I think it's a passion, but obviously people weren't convinced.
I was stunned. I thought it was a no-brainer. Initially, I had a little bit of money, in fact, to even help the process. And I went to my alma mater, the London School of Hygiene and Tropical Medicine, and I went 2 years in a row. And my supervisor for my master's program, she was the chairman of the department. And I did a lunchtime talk, and it was one of these sort of big lecture rooms, and we had students sitting on the stairs. They were packing in. They wanted it. But when I went to them and I said, can you build a program? We can provide materials, we'll get staff to come over, we'll give you a grant to get started. They said, well, it's not one of DFID's priorities. DFID is like the NIH USAID type donor funder. And we don't have people who really are into it. They had 3 pharmacists on the faculty, but they were teaching other things. So I thought, oh, this first year I've obviously got it wrong. So I went back the second year and I primed the pump. And once I did the second year, it became clear to me it didn't fit with the research agenda of the London School of Hygiene. So then I didn't give up. There was somebody, a German, Reinhard Huss, who had been at Heidelberg. He had moved to Leeds. He had set up a program there where he was teaching the stuff. And that was a WHO Collaborating Center for Human Resource Development. So I went over a couple of times, same result. He said, oh, I have research funding, but it's TB and NCD related, or TB and HIV, something. And then I had the opportunity, as part of the Priority Medicines project, I met up with somebody, Bert Lurfkens, from the University of Utrecht. Now, that wasn't a school of public health. That was a school of pharmacy in the Netherlands, but he was the head of he was on the European Medicines Agency, and he was big deal in the National Regulatory Agency. And I said, well, how about, it wasn't my plan to work with pharmacy, and we set up a program there. So we had a professional PhD program where people in mid-career were able to do PhDs. Now, what I didn't know at the time is the Netherlands has a scheme for, they have pay for performance for PhDs. The government gives the university 60,000 euros for each graduating PhD student. Now, most of that money for the regular type of PhD is used for salaries and support. But if people were working somewhere else and they were just coming 1 week, 3 times a year, that was small money for them to make a whole fat profit. So that program suddenly started to do quite well, and we struggled to have the supervisors. And we got a sustained body of research coming through as far as that goes. But that was the only one I succeeded. Africa, I tried, and now that's why I'm at University of Western Cape. I tried there, I did 2 rounds of activities there, and it just didn't gel. They didn't have the critical mass of people to do it. And I think what I really like about the BU setup is this idea of a critical mass of people interested in the topic. We've got the Erins, the supply chain, we've got the epidemiologists, we've got the pharmacists, we've got other people that can work together. And that's what I'm hoping will make it all happen and come together. And as Stefan said, we are getting now more and more requests of people to say, can you help us develop indicator systems? Can you help us develop methods for evaluating pharmaceutical access programs and that? So I'm very excited. I'm a little anxious. Be careful of what you wish for. We may have just too much coming our way, but I'm sure we can find ways to involve other people in that way. But that would be my insight. But I don't know, Veronica or Warren?
Well, I want to push it a little bit. Do you think it's possible that business schools in Asia and Africa might be interested in? It would be nice to get a cadre of entrepreneurs.
Sorry, take the microphone so we can hear on the
young
street.
entrepreneurs from Africa and Asia who are interested and know something about public health. To me, it's the business end that's so interesting. There's no answer, but I don't know whether you think it's even possible.
Yeah, I discussed it in a couple of places where we had the MBA, MPH type programs, and we've had great success. The MBA, the BU MBA, MPH students, the MBA students have to do 400-hour practicum. That's marvelous for you as a supervisor. And they have a work culture that they really work very hard. So that happens. But there's not so many of them, and so far we haven't succeeded. But clearly there is an opportunity for people to go forward. But I do think it coming back to my learning from the London School of Hygiene, it is this research agenda. Institutions, higher institutions, really revolve around the development and sharing of knowledge. And just teaching and just consulting isn't enough without a substantial research agenda, would be my suspicion at this time. But other comments? We don't have many people. The question I always ask pharmaceutical executives and CEOs is how many MPHs do you employ? And in a company that employs 60,000, how many do you think it is, Frederic?
We had a chat about that yesterday. I will just say I've got no idea. I'll check.
But it may well be less, it may be 5.
Yeah, let's put 2 hands.
10, all right. But, doesn't it tell us something that pharmaceutical companies haven't got into the business employing public health graduates? And I hope we'll see that. What we're starting to see now in the employment outcomes, we're seeing lots of our new graduates going into fascinating positions that are coming for them. Sorry, go ahead, Fred.
On that, I'd like to just react on that. My question is it that way? Is that because the industry doesn't attract those students, or those students do not know much about this industry and do not naturally go into this industry? And I think that's where the dialogue is very important. And that's where, in my company, what we've been doing is just we've been putting together access dialogues, so multi-stakeholder platform where we meet with academia, public sector, NGOs, experts, in order to get a better understanding of the challenges and help us inform our strategy. But we're starting to learn about it, and we're starting to engage with students in order to attract the best. One thing which is very important for us is definitely engaging in evidence-based decision-making, and the kind of research and work you're doing is extremely valuable for us. There are many options. It's a new area of engagement, access. We don't have the silver bullet solution for everything. We know it's very complex. We are testing new models, and the only way forward is just to have a strong framework and monitor and measure performance in order to make distinction and choose between what is successful, what is not, and ensure that we can scale up and replicate. But we're not there yet. We're really at the investigative time, and the kind of support you can give us, whether in monitoring, but also in framing from the very beginning, is extremely important for us.
I think we're going to learn as we go along.
And I think just to the question of are we, are pharmaceutical companies or industry, whether it's a pharmaceutical company or a CRO or someone engaged in this area, do they know about MPH students? Do MPH students not want to go into those areas? And I think it's potentially a little bit of both, but I think it's something that we've been very purposeful at BU, at least particularly since it's been my mission since last year when I came on, to really engage with the broader community and get the broader community to know more about what we're doing. Because I think some of it is unknown. I don't think pharmaceutical companies necessarily think of schools of public health. They think of business students with health sector management, kind of business MBA degrees, or more bench science, hard science, clinical science. But that's part of what these events are for. It's part of what we're making with our career services office, doing a lot of work to connect with different companies, and also with our external advisory board in different relationships, trying to promote what it is we're doing here and to show that there is a lot of value. And I think our students, our pharmaceutical students, when they come back after all of their practicum experiences, all have excellent things to say about the different things that they've been doing and think very highly of what they've been able to contribute. So we're going to keep working. Other questions? Yeah, Brooke.
So I hope the question doesn't seem unfriendly, because
No.
it is in fact a friendly question. The slide you put up, I only saw one non-industry entity. I saw the Veterans Administration, but I thought every other place where your students had gone, your graduates, was actually a pharmaceutical company. Maybe you didn't put all the others up.
Yeah,
Okay.
I'll let you finish. But
Okay, so one is, why use those optics? Why point as much to industry as you do? And this somewhat also then comes back to Richard, because I think Richard has, through long experience and understanding of the political economy in which these questions arise, and how actually contentious and hard the issue is. If we want to change the model, if we want to advance public health, there's going to have to be continued involvement with, but sometimes confrontation with industry and with the government. Those are political and economic struggles. They require expertise and various kinds of expertise. And your students, I think, want to develop those skills as well. And many of your students who probably come to the program are motivated in part because of that public health, public interest focus. And part of the difficulty that such students have is graduating with some degree of debt. Where am I going to get a job? Can I go to work with Peter at, in Washington? Can I work with MSF? Can I work with HI? Where can I do the work that gets at some of the structural problems that persist in this field? And so the question is, what can we do to better inspire and identify career opportunities and the kind of networking with those possibilities with the same energy that might sometimes be going into the more readily accessible private sector involvement?
sure.
Veronica, want to
maybe I can respond a bit to that. As a faculty member, I have currently a student working with medicines, MSF in Mexico in the country office. It's a graduate of our program, pharm student, who was able to make that connection via us as faculty members, but now is really, really engaged in a fascinating project around including medicine access in Latin America. So I think that's just one example of how we push the agenda, not only in terms of dialogue with the industry or working with the industry, but also on the sector that you point out, and enabling our students to engage in very informative and meaningful debates.
And if I can just give a few examples of some of the students that I've placed in WHO offices. We had somebody, one of the MBA, MPH students, went to Manila to help develop or do a study on antimicrobial resistance policies in the region. And she was paired with a consultant and produced a report. And that report served as the basis for the strategy for the Western Pacific Regional Office strategy. And the moment she graduated, they had her back for 6 months as a consultant, and then she stayed another few months. But now she's back here looking around. I think she got a job. I'm sure, Travis, you would know. But those are some of the things. But we've placed people in Delhi office. We've placed them in the Geneva office. And there are Gavi, Kate's here, had a spell at Gavi in Geneva. So yes, it is. If it wasn't shown on the other sides, that's just an oversight. So.
Yeah.
You want to carry on?
Yeah, and I was just going to say for that particular slide anyway, it was a sample. JSI and MSH were also on there as non-governmental organizations, and I appreciate the feedback on that. We will have a more representative sample of what our students are doing, but people certainly go on to all of these different areas that we've been talking about, whether it's government policy. We hosted the Universities Allied for Essential Medicines conference here at BU last year and have a number of students interested in that. And I think we really see, these are Masters of Public Health students, so they come at this issue from a public health perspective and everything that we've been talking about. And I think a lot of them do wrestle, I know from having spoken to some of them, wrestle with, in going into industry, wrestle with some of these ethical questions of what have I been learning in school, and how am I pushing access agendas forward and things like that in either a larger company or a smaller company. But I think they're getting a lot of experiences. And the other thing we try to do is in our seminar series, bring in a variety of people to expose, from alumni to just connections that we have, to expose them to these different things that they can be doing after their degree. Ooh, a whole bunch of questions. Go ahead, Mike.
I think you're doing a great job of helping the public
Sorry, do you want
health.
to introduce
Sorry,
yourself?
Mike Watson from Valera. Of helping the public health community reach out and understand and bridge out towards the pharmaceutical piece. Have you thought about how you could do that in the other direction and help the pharmaceutical side understand better the public health side? You talked about what pharma companies do. Coming from pharma, I can be even more black and white about that. In many cases at the top, they're doing two things. They're making investment decisions and they're managing risk. And people who are doing that don't come from a background or have time or even thinking about the public health piece. And just, if you can get in there, just get in front of the boards, not in an evangelical sense, just get out there and tell the story and then leave. You'll start to maybe build the bridge back in the other way as well.
Good. Well, as president of your company, I hope you'll invite us to talk to your board.
We're already converting.
Yeah.
Jonah? Oh, okay. No?
Hi, my name's Tamara Wyzanski. I graduated 2 years ago and I work at Vertex Pharmaceuticals. I guess for me, in my experience, just to speak to some of the disconnect of going into industry, I think that I went into public health thinking that everything is behavioral. I was in maternal and child health. We studied social and behavioral science. So I just assumed that pharmaceuticals was like a last resort of intervention, and we prevent smoking by doing everything possible to change behavior, and the nicotine patch is like not the way to go. And for obesity and all that, diet and exercise, and then pharmaceutical intervention is an absolute last resort. So I think that it's just too black and white, maybe in the School of Public Health when I was there. I think it sounds like it's changing, but my experience was everything can be done with changing behavior. And I work in cystic fibrosis. It's genetic. Nothing you can do in your lifestyle will change that you have cystic fibrosis. So I think that I landed at a company that really has exhausted all options in terms of changing behavior. But I think that it's just an area to kind of explore in terms of getting students to understand that it's a partnership between pharmaceutical intervention and lifestyle change, and they can partner together, and that's really the relationship between medicine and public health.
That's very useful.
Yeah. And I think also one thing that we just covered in our first class of pharmaceuticals and public health is looking at a pharmaceutical as a means of prevention. So something like pregnancy prevention, and looking at the Kaiser Family Foundation just came out with a report that teen pregnancy rates have gone down because of in the United States in terms of due to increased use of contraceptives, but rate of sexual activity stayed the same. So it was the use of contraceptives that had prevented unplanned pregnancies in younger people. So we can speak to that. And I think, Mike, to your point, some of the things that we're planning on doing this year and that I've been talking with our external advisory board about are actually doing just what you suggested and going physically to, not having people, if any of you are familiar with Boston, many of the pharmaceutical and life sciences companies are across the river in Cambridge. Vertex is over here, but physically going there and having more informal talks, things that the different companies can share with us, and then have a faculty member, student, someone come over and also present, and then have an informal discussion in meetings like that. Because I think while we try to have events like this and do our best to invite all of Cambridge to come over here, we need to be making that step over that way.
Yeah, one thing, I'd ask the question, where's the common ground and where's the future? And because I think some of what is highlighted here is kind of the issues that we've been dealing with. Some are, the direction's pretty clear, we just got to keep on it. But in terms of the future, I mean, for one thing, we know chronic diseases. And the thing that is baffling is that is in some ways the biggest chunk of low-hanging fruit, because we talk about adherence. Am I taking all the drugs the way that I'm supposed to take every day? But there's persistence. Do I keep on it for a lifetime? And there's this huge fall off. I mean, we heard it in terms of the antiretrovirals and all here. The other part of the future is much, much more person-driven, patient-driven care. And so, I mean, I think that is thinking about where things are going in the common ground, because there's huge common ground with the pharmaceutical industry because they get people started on drugs and they don't stay. And that goes to two other things. One is the disciplines and one is the research. I maybe misheard it, but it sounds, I thought I heard that there wasn't so much research to do in this field. I think there's a lot of research to do in this field because we haven't solved all the problems. And on the disciplines, I mean, with Dean Galea's recent book on population health science and the range of skill sets that it's going to take. So I actually think there is more common ground to provide the sort of skills that would be in the benefit of both the population and the pharmaceutical industry. And that's a win-win that I think is under-reflected in the way that you've conceived it at this point.
Sure, and I think you're exactly correct in that NCDs are an area that will be the future. Thinking about what is the intersection of precision medicine or individualized medicine and public health, and all of those have implications for what are we looking at for the future in terms of what we're teaching, where are we looking at for research opportunities, where are we looking for collaboration with companies. And I think those are two areas that we've been talking about, and we can certainly present that in a better way in our slides. But I think something that we also look at what our students are interested in as well. I mean, and research, as a research institution, it's what our faculty are interested in. And I think with our group of faculty, we're also looking for new young faculty and bringing on new researchers who are doing more and more work in this area. we'll take like one or two questions. So here, and then with Marg up here. Yeah.
I'm just thinking out loud a little bit. I know sometimes like development of building those type of companies, sometimes if they're building big, huge apartment buildings, they need to put some type of money into low-income developments that may need to go into a general fund and that some other contractor builds. Has there ever been any talk about pharmaceutical companies putting aside some money, because we know they have them, putting aside some money to promote lifestyle changes that would basically alleviate the need for pharmaceuticals, basically like for high blood pressure cases or heart disease, you know, maybe putting money into community-based health programs that could alleviate the need for the pharmaceutical. I'm just kind of thinking as like a mitigation for something like that. Has that ever been a concern or discussed at all? And perhaps when you go to the pharmaceutical companies, that could be an option or an idea you could present them with? I'm just thinking out loud.
Sure, and I think many do. I mean, many do have community programs, a lot of patient advocacy. Many pharmaceutical companies are going into, you know, bringing in the perspective of the patient more, and also thinking about the preventative side. So you're thinking about, I mean, you could think about big tobacco and all that they've been forced to do in terms of smoking cessation or prevention and regulation on them. But it's definitely a discussion point that we could bring in those conversations with companies. I don't know if you...
Yeah, I think there have been some activities. One of the areas, and it gets a little, I don't want to say murky, but Novo Nordisk, for example, which is the dominant insulin manufacturer, they have funded the World Diabetes Foundation, and that is nothing to do with cure. They're not using it to sell their medicines. It's disease awareness, it's children's programs, how do you cope with a child in a household who has diabetes, all of these interesting things. And when you look at the individual projects, you think how innovative and how interesting. But at the end of the day, the Novo Nordisk logo's on the bottom of the posters and the thing. Is it partly that? So I think companies can do some things very well. I worry about prescriber education. When does prescriber education end and market promotion begin? This is one of the difficult challenges. And here in the US, of course, with the Sunshine Act, all of those interactions have to be documented and reported. So it's a little confusing sometimes as far as that goes. But again, it's eminently researchable. And I would hope, and coming back to what Jono said, is when we say about research, it's not just having a good research question. We can fill a book with those. It's finding somebody who says, I want to pay for you to answer that question. And that, unfortunately, and if we look at USAID's policy, they have a policy that NCDs is not a health issue. You know, who would have thought it? But they will not fund NCD interventions. 60% of the world's morbidity and mortality, and they will continue to fund programs that don't address NCDs. So I think we have one last comment.
My question is very different. Seeing Jono here today has reminded me about WHO, and when I started working with the medicines department, you were the director, and I have to say it was really good times. I was there probably once a month, every other month. We worked hard. There was many people there doing interesting work with various different partners. Now I see a different WHO headquarters. You can almost, you know, fire a pistol down the corridor. You won't hit anybody because there's very few staff there, and it seems they are inadequately funded. And this is WHO. They're supposed to be, you know, the authority that you go to for all the issues, you know, in medicines and, of course, all the other divisions of WHO. But my focus is on, of course, the Pharmaceuticals department. What do you see is going to be the future of WHO, because I don't see them as being this dominant, and working hard, really making a difference, leadership and everything that it was. Do you think it's been devolved to the regional offices now? Is it the local country offices? What is it? Because I worry that WHO is becoming weaker and weaker. So I'd be really interested to hear, you must have thoughts, you work with them in different ways. Am I wrong in thinking and being concerned about WHO? Or what?
Want to try? I do think organizations wax and wane. And before you went to WHO, before 1977, when it was the essential medicine, it was just a regulatory. They produced the International Pharmacopoeia, the Committee on Specifications, and that was all. And then Hafton Mahler came in, he recruited somebody called Ernst Lauritsen, and there was a big access movement, and everything went up. But nothing is forever, and I think things wax and wane. And if BU's School of Public Health and the pharmaceutical program can become a stronger influence as WHO's influence declines, I'm not going to cry for WHO, but Jono, you were director. You've seen how things have changed.
Yeah, actually, I've followed it less in the last 10 years. I haven't been in the halls, but I do think we do have an issue, and that's just an example. I mean, it's been a problem getting the WHO dues paid for decades. And it's a real dilemma. And we're in a world right now where people in general, not just with WHO, are kind of cynical about and I think things do go in phases, cynical about governments and sort of collective institutions. We tried sort of keeping hands off of the private sector with the economy and basically put millions of people out of job, out of retirement and all when we melted the economy. So it's not that you want all of one or all of the other. And I think the basic question is, in whose interest is it to get it right? And so what I am encouraged about is some of the new generation of advocacy, Global Citizen, if folks are aware of Global Citizen. And I think, Margaret, I hate to say it, but it's back to the public and public interest and all that's going to put the pressure on the policymakers, because we heard about the counterforce of vested interests. It's there in every aspect of life, but I think the building movements that will really keep an eye on the public good and get people to understand. I think it's wonderful that the courts in the U.S. are letting a bunch of youthful folks sue the U.S. government for letting global warming happen, because it's a constitutional right to have a safe place to live, and the courts have said these young folks are going to be here long enough to suffer the consequences. So it's also taking action, legal action where you can. So I think it's a mixture of things. I feel sad for the changes that have happened, but it's really clear that we need an international body that has the convening power. WHO is the only organization in the world that can declare a global health emergency, and it cancels an Elton John concert in Toronto. That's because of the SARS epidemic. But there are a few authorities WHO has. We need it, and I hope it comes back. But it's going to come back because people get what's in their interest and want to put time into looking out for their collective interest.
Well, thank you. Very quick
brief
comment, and then we're going to finish.
I think what Jonathan says is right, but I want to differ a little bit to say there is a general growth in knowledge. At first, WHO was the authority, but now most of the UN agencies, as you will see, basically all of them, they act more in advisory role. Countries have grown very strong, even to oppose what a UN Security Council or what UN will say. The same with WHO. They are big organization. Boston University is a big organization. Knowledge has grown, and so I would think expectations are growing, but we should not expect so much from some of these UN agencies now with the knowledge that we see in society.
Thank you, Pius. Well, thank you everybody for all of your comments and questions. We are going to close by having Dean Galea come and say a few closing words, but thanks everyone for your attention, and we'll talk to you soon.
So one of the great privileges of being dean is that I get to spend a day and actually learn about things I know a little about, so this has been terrific. One of the dangers of being dean is then I get to stand between you and drinks. I realize that, so it's a bit of a mixed bag. But I want to just make 3 comments about 3 issues that I thought emerged for me from today, and then I want to make 3 comments about the role of the university around these issues, which I think was really nicely emerged from the last panel. So these issues draw from comments that speakers have made. So the first point I thought was this concept I really liked: access is like faith, hope, and charity. You can look at it in multiple different ways, which I actually thought it was a really nice idea about the complexity of some of these issues we're dealing with. And in many respects, I think it's very easy to have a reflexive, hardline position on what access actually means, but it really bespeaks the need for careful, thoughtful scholarship about what we mean by access and how one gets to it. That's point 1. The second point, and I'm now going to quote my colleague Soji, because I love this quote. He put it up on a slide, but he went very quickly. It said, "Ideological absolutism and romantic attachments to perfection are not virtues in the practice of public policy." Now, I might argue that ideological absolutism and romantic attachment to perfection are never virtues. But I actually thought that this was a really important point, because when you're dealing with complexity of issues like pharmaceuticals and public health, if our goal truly is the improvement of population health, which Jonah was kind enough to refer some of the work I've done recently on this notion of population health, we are not well served by ideological absolutism. We're not well served by romantic attachments to perfection in one aspect or another. These are extraordinarily complex issues which rest on deeply embedded social, economic, political structures that are not going to change overnight. And it doesn't seem to me to advance our goal. And I see our goal at bottom line as improving population health by taking hardline positions that do not have space for nuance and complexity. But at the same time, of course, it does not preclude principle and clarity of position. So second point. And the third point is that what ultimately moves these issues are social narratives. And social narratives are constructed through knowledge, through the construction of values. And it is this kind of discussion, like the one we had today, that ultimately builds social narratives, which then brings me to my 3 points about what's the role of the university. And since I have been at the school, I have really been saying the good news is universities only do 3 things as far as I'm concerned, but those 3 things are really important. The first thing is we generate knowledge, we think. And the universities are the one institution in society that is paid to, where society invests in these institutions to think of approaches, think of solutions, to ask questions, and to find answers to those questions. And it's complicated, and those of us who have the good fortune of being in universities spend a lot of our time whining and complaining about how hard it is. But actually, at the end of the day, it's an extraordinary privilege that we are actually paid to think and to try to come up with solutions. And I thought today was a brilliant example of that, of people who are wrestling with trying to come up with solutions to difficult questions. So that's point A. The second role of universities is to teach. And we teach our students. There are a lot of students here today. A lot of the speakers made reference to this. We have a responsibility to transmit that knowledge to the next generation and to inculcate the students into the difficult task of finding nuance, inculcate the students into debate, discussion, and airing of multiple, sometimes contradictory positions around complex issues. And this is a complex issue. I would argue, actually, that any issue that is interesting is complex, almost definitionally. And this is our job as a university, to have students prepared to deal with these complex issues going forward. The Pharmaceutical Public Health Program does an outstanding job of this. It takes a difficult issue. I sort of shared Richard's ambivalence about it. It's sort of nice to know that we're front and center on this. It's also kind of sad that we're the only ones who are actually so far out front. One would like to see this more generally. But I think this is a really core role of what we do as a university. And the third part is it's not enough. It's not enough just to generate knowledge. It's not enough just to teach it to our students. We actually have a responsibility to be involved in the doing, in the translating that knowledge, in engaging in the construction of those social narratives. Because ultimately those social narratives are driven by knowledge, and they're driven by the generations of public health practitioners who are emerging as our students. I think the era when those of us in universities had the luxury to stay dispassionate and sort of behind in the cloister and just saying, let's have big thoughts and put them in books, it is long over. It is our responsibility to make sure that we are actually in the arena and bloodied. And I think sometimes it's a tough balance. It's a tough balance to try to figure out how one is in the arena, how actually one shapes social narratives, while one also is trying to generate knowledge in a way that is truly faithful to the idea of asking questions and answering them honestly. But I think it's a balance that we have a responsibility to somehow figure out a way to get to. And I thought today did a brilliant job of highlighting that, of showing us how we as a university can engage around a difficult issue. I am deeply indebted to everybody who put today together. I'm deeply indebted to all the speakers. I thanked everybody who was behind organizing it all this morning, so I will not repeat the names, but I do want to ask everybody to lead a round of applause for Professor Laing, without whom this would not have been possible.